This is where we left off last time, and we were talking about how cardiac output is affected by cardiac rate, heart rate, and by stroke volume. One of the things that influenced stroke volume was end diastolic volume. And if you remember, this is the volume inside the ventricle right at the end of diastole. This is when the ventricles are most full of blood, is right before they enter systole. So let's take a look at some of the things that influence this end diastolic volume. So the things that influence end diastolic volume are things that affect what's called venous return. And venous return is influenced by the total blood volume. The more the blood volume goes up, the more blood there is to return to the heart, and by venous pressure. This is the driving force, moving blood then through the veins and back towards the heart. Anything that's going to increase venous pressure will also increase venous return. Veins have a very high compliance compared to arteries. As they stretch more easily, they don't have as much blood pressure in them, and as a consequence of being very stretchy, they have a very high blood volume to them. They're referred to as capacitance vessels as a consequence, and about 2/3 of the blood in the body at any given moment is over here on the venous side as a consequence of that high degree of capacity. They hold more blood than the arteries and maintain a lower pressure. So things that influence venous return then is also the difference between the mean arterial pressure and the venous pressure. And the mean arterial blood pressure is about 100 millimeters of mercury. The venous pressure is about 0. So the venous pressure starts off as the highest in the venules. These are the little bitty veins that are leaving the capillary beds. And then by the time it reaches the right atrium from the vena cava, that pressure is about 0. So the difference between the mean arterial pressure is about 100 millimeters of mercury, and the venous pressure at the right side of the heart is about 100 millimeters of mercury. This is the driving force to bring blood back to the heart. Sympathetic nervous system activity can increase venous pressure because it causes the smooth muscles of the blood vessels, including the veins, to contract, and this reduces compliance and raises then venous pressure. Skeletal muscle pumps, as we've discussed before, are squeezing on the veins, and since they have one-way valves, the blood is forced to go back towards the heart. There's also the respiration that's driving this as well. So as we breathe, the diaphragm moves down, causes compression of the abdomen, and so this then causes blood to be squeezed back towards the heart, but it also opens up in a vertical direction the size of the thoracic cavity, the chest, and as a consequence causes a bit of a vacuum there, and this helps to suck blood back towards the heart as well. And then, as I mentioned, anything that affects blood volume is going to affect venous return. Anything that increases blood volume will increase venous return, and anything that decreases blood volume will decrease venous return. So let's take a look at this in a little bit more detail here in a chart. And so venous return, we're discussing this in the context of cardiac output because if venous return goes up, this causes an increase in end diastolic volume, which causes an increase in stroke volume, which causes an increase in cardiac output. Everything in this diagram has a series of arrows in it. The solid arrows are things that are going to increase something, and the dashed lines are things that mean they're going to decrease things. So venous return, of course, it's affected by blood volume. If blood volume goes up, venous return goes up. But blood volume can go down by increasing urine volume because that liquid in the urine originally came from the blood. And anything that increases tissue fluid volume is also then going to decrease blood volume because, well, what's in the interstitial space came from the blood as well. Breathing is going to cause an increase in venous return for two reasons. One shown right here, that is the negative interthoracic pressure. It's going to suck the blood back towards the heart, but also compression of the diaphragm on the abdominal cavity squeezes blood back towards the heart as well. And then anything that raises venous pressure is going to increase venous return. These include the skeletal muscle pumps that are squeezing on the veins and pushing the blood back towards the heart. And then anything that causes vasoconstriction, that is contraction of the smooth muscle in the veins, will do that as well. And this is the sympathetic nervous system activity then that causes tension, causes contraction of the smooth muscle in those blood vessels. So then let's look at a little more detail about blood volume. If you remember, About 2/3 of the liquid in our bodies is in the intracellular space, that is inside of cells. And of that remaining 1/3, 80% is in the interstitial space, and 20% is in the liquid part of the blood plasma. So this is the extracellular compartment, these two spaces, the interstitial space and the liquid in the blood. This is controlled in turn by osmotic forces that are helping to hold the liquid in the blood and reducing the ability of the liquid in the blood then to move into the interstitial space. Also, urine formation and water intake influence blood volume. The greater the formation of urine, the more blood volume goes down. The less water you take in, the more blood volume goes down. And the reverse is true as well. The lower the urine formation, the more blood volume goes up, and the more water you drink, the more the blood volume goes up. And as you'll see in a moment here, fluid is always circulating back and forth between all of these compartments. So that's what this looks like here. So here's the intracellular compartment. As mentioned, about 2/3 of this right here, 2/3 of the water is found inside of our cells. And then the remaining 1/3 is divided between the interstitial space. About 80% of that 1/3 is in that interstitial space, and about 20% is the liquid part of the blood plasma. And then there's a constant dynamic change here, or exchange, I mean to say, based on mechanisms that cause us to lose water versus mechanisms that allow us to gain water. So the water that we're gaining comes from the liquid that we drink and also food that has water in it. And so this contributes to an increase in liquid volume in our bodies. Some of that is lost into the GI system and is eliminated as feces. And then we lose water through several other mechanisms. And we'll get into more of these in detail a little bit later in the course, particularly when we talk about kidney function. So the kidney regulates then blood volume by regulating urine volume. And as we'll discuss in the respiratory section of the course, the moisture in the air that we exhale then influences blood volume as well. We inhale air, we saturate that with water vapor, and then every time we exhale, we lose a little bit of that. And then we can lose water through sweating, through perspiration as well. So there's constant dynamic equilibrium going on here between the water that we take in, food and drink, and the water we lose by these other mechanisms. So other aspects that influence then this dynamic equilibrium is the net filtration pressure. So this is the hydrostatic pressure. This is blood pressure. This is blood pressure that's in the capillaries versus the pressure, the hydrostatic pressure that's in the interstitial space. So pressure in the capillaries is driving liquid out, and pressure in the interstitial space is pushing that liquid back in. The pressure in the capillary bed also varies significantly from the arterial end of the capillary to the venous end of the capillary. It starts off, for example, at about 37 millimeters of mercury at the arterial end, and then drops along that capillary bed down to 17 millimeters of mercury by the time it reaches the venual end. The hydrostatic pressure this is driving liquid out. The hydrostatic pressure in the interstitial space is pushing fluid back in. As you can see, it's not much. It's only about 1 millimeter of mercury. So the net hydrostatic filtration pressure then is about 37 millimeters of mercury at the arterial end. That is 36. That is 37 millimeters of mercury minus 1 to make 36 at the arterial end. And it's about 16 at the venual end. That is 17 pushing it out in the capillaries, and the 1 millimeter of mercury of hydrostatic pressure in the interstitial space, pushing it back in. So the other part that influences this is something called colloid osmotic pressure. It's called colloid osmotic pressure because it's proteins that's dissolved in fluid. A colloid suspension is like milk, for example. It is cloudy, it's not clear, compared to something like Gatorade that isn't a colloid. Those molecules are completely dissolved in the liquid, and the liquid is clear. So a colloid is really a suspension rather than being completely dissolved. And the proteins that are in the blood then play a very important role. in helping to hold the liquid in the capillaries. The protein that we're discussing here is primary is albumin. And it generates something then that's referred to as oncotic pressure. Oncotic pressure is pressure that's contributed by the presence of proteins in the blood. And it has about 25 millimeters of mercury then that is helping to hold on to the fluid in the capillaries. Oncotic pressure in the interstitial space is about 0. Typically, you don't, under normal conditions, have any protein oncotic pressure in the interstitial space. So all of this protein-derived pressure is helping to hold fluid into the capillaries. So this then raises a way of calculating this as something called the Starling forces. And so it's a combination of the hydrostatic pressure and the oncotic pressures then that determine whether liquid stays in the capillaries or it moves into the interstitial space, and how much of that moves. Okay? So if we look at the details of this, it looks like a lot of complicated items in here, but it's really not that hard. It's fairly straightforward. The fluid movement then should make fairly good sense. It's the stuff that's pushing the fluid out. Okay? So this is the capillary hydrostatic pressure pushing the fluid out, the blood pressure that's pushing it out, plus the other part that's driving it out is the osmotic, colloid osmotic pressure in the interstitial fluid. Well, and that's basically 0. And then what's holding the fluid in is the hydrostatic pressure of the interstitial space. Well, that's not much, about 1 millimeter mercury, plus the colloid osmotic pressure of the blood plasma. That's about 25 millimeters of mercury that's holding it in. So let's take a look at that in more detail with this diagram. So here's the arterial end of a capillary bed, and here's the venial end of the capillary bed. And as the blood is flowing from the arterial end through the capillary to the venial end, the blood pressure drops. It drops rather considerably. So it starts off at about 37 millimeters of mercury here on the arterial end and drops down to about 17 millimeter mercury till it reaches then the venial end. So how does this then define the details of how much fluid moves into the interstitial space versus how much of it stays in the capillary bed? Well, here's the net filtration pressure. That is the driving of fluid out. And so it's 37 millimeters of mercury on this end here. And then the part that is holding it in is 26 millimeters of mercury. So the net filtration pressure is 11 millimeters of mercury driving it out on the arterial end. But what happens as we move along the capillary bed is that the hydrostatic pressure drops. Everything else stays the same, but the hydrostatic pressure drops, and it drops quite a lot. It drops from 37 down to 17. So then when we do the math on this is 17 minus 26. This ends up being a negative number. So minus 9. So this is absorption that's happening. So we have 11 millimeters of mercury driving it out on this end, and 9 millimeters of mercury pulling it back in on the venial end. If you do the math on this, you see that actually, well, you lose more than you gain. So there's 11 millimeters of mercury being lost over here and only 9 bringing it back in. So that ends up with a net filtration pressure through that capillary bed of 2 millimeters of mercury. So that's what this is saying. Not 100% of it is recaptured at the venous end. About 10 to 15% of that liquid that was in the blood then remains in the interstitial space. And then that gets picked up then by the lymphatic system that we've discussed before, and then that eventually gets brought back then into the venous blood supply. So let's take a look at the kinds of things that influence this, because this is clinically significant, and you will encounter these kinds of things when you treat your patients. So edema, this is swelling. This is excessive accumulation of the interstitial fluids. And there are a variety of things that can affect this. Well, one is high arterial blood pressure. So let's go back to this slide and take a look. So if we raise this from 37 to, say, 57, now this net filtration pressure is quite large. And it would never get to a negative number as it reaches the venial end, so you're always going to be pushing out a little bit of liquid. This will cause too much fluid to leave the blood vessel and end up in the interstitial space and cause edema. Another is venous obstruction. So let's go back to the slide again and show if you block this, this is going to cause this to back up in the blood vessel here in the capillary bed. This will push liquid out then into the interstitial space that can't be recaptured if you have venous obstruction, and this will cause edema as well. Leakage of plasma proteins into the interstitial space. So if you remember, the oncotic pressure in the interstitial space is basically zero, but damage to blood vessels, other kinds of things can cause then an increase in plasma proteins in the interstitial space and reduce the difference of that 25 millimeters of mercury holding it in versus the normal zero that should be that interstitial space that's pulling that liquid out, and this can cause edema as well. Myxedema, this is a hypothyroid issue, and this is an accumulation of a type of protein called mucin in the extracellular space, and so this can help to draw fluid out of the capillary bed as well. A decrease in plasma protein concentration. So it has 25 millimeters of mercury normally, and almost all of this is because of albumin. And albumin is a relatively small protein, as I've mentioned before, that's made by the liver. And there can be a couple of reasons why this can be lowered. Well, one is starvation. If you simply don't have enough food in your diet, particularly proteins in your diet, you're not going to make enough albumin, and as a consequence, then there isn't going to be enough albumin in the blood to hold the liquid in the blood, and instead that liquid's going to end up in the interstitial space. Another not uncommon is liver disease. If you have liver disease, there's a variety of ways that one can have that. This will result then in a reduction in the amount of albumin that can be produced, and as a consequence, you have fluid that leaves the capillary bed and ends up then in the interstitial space. Lastly, here is obstruction of lymphatic drainage. So let's go back to that slide here again. So you have issues that block this lymphatic system here, then it's not able then to pick up the liquid that's normally being moved from the capillary bed into the interstitial space, and this can lead to edema as well. So here again is a chart showing a table showing all of these different kinds of issues, and most of this is saying just exactly what I told you in the last slide. What I want to come back to here is this obstruction of lymphatic vessels, and one instance of this is a roundworm that's transmitted by a mosquito bite, and this causes something called elephantitis. And so here's an example of an individual who is affected by elephantitis in their right leg. And you can see the massive increase in the interstitial fluid that is accumulated as a consequence of this blocking of this lymphatic drainage. Sometimes this is referred to as third spacing of fluid. And so you have three spaces for fluid. Intracellular is one space, inside the blood vessels is a second space, and the interstitial fluid is a third space. And so sometimes this is referred to as third spacing.